welcome back, everyone. We're from lunch. Our next session I'm very excited about is a research showcase of research that has been funded by the USD Prescribing Research Network. I'm going to introduce our moderators, who are the co-leads of our pilot and grant planning core. Dr. Amanda Mixon is Associate Professor in the section of Hospital Medicine at Vanderbilt and a research scientist at the VA Tennessee Valley Healthcare System. Her research focuses on improving medication management and deprescribing in transitions of care. She's also served as an expert for the World Health Organization's Global Patient Safety Challenge on medications without harm. Her work has been funded by the VA, PCORI, and NIH. Sitting beside her is Dr. Sandra Simmons, who's the Hamilton Chair in Geriatrics and Aging Research and a professor at medicine in the Division of Geriatrics at Vanderbilt, as well as having a joint appointment in the Department of Psychology. She's director of the Vanderbilt Center for Quality Aging and the Deputy Associate Director for Research at the Tennessee Valley VA Healthcare Systems, GRAC. A psychologist and gerontologist by training, Dr. Simmons' research focuses on clinical and behavioral interventions to improve quality of life and quality of care for older adults across the continuum. So thank you, Sandra and Amanda.
It's a real pleasure to be with you all today, and we're going to have our first speaker, who is Dr. Anna Hung, who is an assistant professor in the Department of Population Health Sciences at Duke, and a research health scientist with the Durham VA's Health Services Research and Development Service. Her research focuses on payer and patient decision-making related to pharmacy benefits, and she's worked with a variety of managed care organizations to assess their drug utilization and clinical management programs. Dr. Hung is a USD Prescribing Research Network pilot awardee.
Hello. Great, so I'm going to talk a little bit about the study that we had funded by the USDeN, and this was a study looking at Medicare's MTM program and its impact on potentially inappropriate medication discontinuation. So first I want to thank USDeN for the funding, as well as through a lot of support and mentorship through the JII program. We also had internal funding from Duke University. And I also want to thank our Stakeholder Advisory Board. I see a couple members in the audience, and this was a great 6-member board representing multiple perspectives, and they were a dream team, honestly. And I also want to thank our study team, of course. A couple folks are also in the audience. So what is MTM? MTM stands for Medication Therapy Management. If you're a pharmacist, you probably would have heard about this in pharmacy school. It's a nationwide program that has been part of Medicare since 2006 with the advent of Medicare Part D, which is prescription drug insurance in the US. As part of this program, Part D plans are required to offer MTM services to beneficiaries with multiple chronic conditions, multiple Part D drugs, and high drug spending. And the reason why we were interested in looking at older adults with MCCs and polypharmacy is that these are typically the folks who are more likely to be using PIMs. And I'm realizing that the slide is slightly cut off, but hopefully that's okay for future slides. And so part of the MTM program is this comprehensive medication review. It's one of the cornerstone kind of interventions, if you will. And typically it looks like a pharmacist or an MTM provider interviewing a patient, reviewing medications, identifying any potential problems, and then going through to educate the patient and then contact the various prescribers if there needs to be a discontinuation of a PIM or some kind of other change to the medication. So we were looking at 3 aims. First, who's receiving CMRs? Secondly, what's the impact of CMRs on PIM use and whether this varies by race and ethnicity? And then thirdly, we wanted to take a different angle and look at what are the most commonly continued PIMs after a CMR as a potential area for future intervention development. So we were looking at Medicare 5% fee for claims, and across the 3 aims, there were different designs that we applied. We were focused on community dwelling Medicare Part D beneficiaries who were eligible for MTM, and we were looking from 2013 to 2020. So first, talking a little bit about kind of who's more and less likely to receive a CMR. On the left-hand side there, you can see that those who are less likely to receive a CMR were older, males, Hispanic, Asian, and North American Native beneficiaries, lower income, so dual Medicaid status, certain geographic regions, and then having a greater number of chronic conditions. And on the right-hand side, those who are more likely to receive CMRs actually were those who resided in rural areas and had a greater number of medications. But one interesting and surprising finding that we came upon during the study was in 2016, there was a new quality measure related to CMR completion rates that Medicare put into place. And one way that Part D plans could increase their CMR completion rates was to decrease the denominator. So that's what you're seeing in the left-hand side there, the blue line. You'll see kind of maybe a slight uptick, plateau 2013 to 2015. After 2015, that number of beneficiaries that plans deem eligible for this MTM program drops. And on the right-hand side there, you can see the yellow line that there's this increase in CMR completion rates from 2013 to 2020, about 10% to 36%, but that's maybe in part an artificial increase. We also looked at racial and ethnic disparities, and Hispanic and Asian beneficiaries were less likely than white beneficiaries to receive a CMR, recognizing that the slide is a little bit distorted, but hopefully you can bear with me. So what we looked at was also before and after 2016, and we saw that the disparity was reduced after 2016, but not totally eliminated. The lines for Asian and Hispanic beneficiaries are the purple and green ones, and then the one for the white beneficiaries is the blue line. Okay, so then we also wanted to know, okay, this nationwide program, what's going on? Are CMRs associated with PIM discontinuation? And so yes, we actually did find an effect, but it was quite small. So 26% increase in chance of discontinuing a PIM, but if you look at the model estimated numbers, on average you're seeing something like 19% of CMR users discontinuing a PIM versus 16% of non-users. And we didn't see a difference in effect by race and ethnicity, but there is small sample size considerations. And then lastly, looking at what PIMs are still remaining after a CMR. So potential targets for deprescribing intervention maybe in the future. So from left to right here, white, black, and Hispanic beneficiaries, we just have reported kind of the top 5 PIMs. And I'll just highlight that paroxetine, glimepiride, and digoxin are on all 3 lists. And so that's all that I have for me today. Thanks.
Our next speaker is Dr. Lisa LaRoche, who is an instructor in medicine at the Harvard Medical School and a research faculty member at the Mongan Institute Center for Aging and Serious Illness at Massachusetts General Hospital. A psychologist by training, Dr. LaRoche conducts multi-method approaches to doing research on health behavior change among midlife and older adults with chronic pain, and approaches to promote adherence to healthful behaviors in this population. And Dr. LaRoche is a USD Prescribing Research Network pilot awardee.
Thank you. All right, thank you. I'm so excited to be here today and have the opportunity to talk about some of this pilot work looking at substance-related outcomes of opioid deprescribing in older adults. So we know that over 1/3 of older adults in the United States have chronic pain, and opioids continue to be commonly prescribed for chronic pain management. We also know that deprescribing opioids can offer numerous health benefits for older adults. However, one potential consequence of deprescribing opioids is that older adults might turn to non-prescribed opioids or non-opioid substances in an attempt to self-medicate pain. So the goal of our study was to use a mixed methods approach to explore relationships between opioid deprescribing and the development of both opioid and non-opioid substance use disorders in older adults. First, we conducted a retrospective cohort study using electronic health record data at Mass General Brigham, and the goal was to compare the effects of opioid dose trajectories on the development of substance use disorders. I'm not going to get into a lot of the methodological details right now, but I am happy to answer any questions later. Just briefly, we identified older adult patients who were prescribed long-term opioid therapy and then subsequently decreased their dose to less than 15 morphine milligram equivalents daily. We looked at what happened in the year following, and almost 95% did eventually discontinue opioids. And we further classified those patients as having either a gradual discontinuation or an abrupt discontinuation. We conducted preliminary analyses to determine whether those who had an abrupt discontinuation were more likely to receive a substance use diagnosis during a 90-day period that included both the 30 days leading up to discontinuation as well as the first 60 days of no opioid availability. And what we found was that those who had an abrupt discontinuation were over 2.5 times as likely to receive a substance use diagnosis during that period. This was largely driven by opioid diagnoses. Differences in nicotine, alcohol, and sedative diagnoses were not statistically significant, although the prevalence rates were trending towards being higher among those with an abrupt discontinuation. So taken together, this suggests that opioid and non-opioid substance use might increase in the context of opioid deprescribing, particularly following an abrupt discontinuation. An important limitation of these preliminary analyses is that we can't necessarily establish the causal or temporal nature of that association. So one of our next steps is to examine more longitudinally the relationship between opioid dose trajectory and substance use over time to get a better sense at the temporal nature of these effects. It's also important that we start to identify ways that we can reduce the risk for substance use in the context of opioid deprescribing. So we conducted focus groups among older adults with chronic pain who were prescribed a stable opioid dose to explore their preferences for an intervention that's designed to reduce risk for opioid and non-opioid substance use in the context of deprescribing. They had lots of recommendations for us. So first and foremost, they recommended having a clear plan for deprescribing. So they wanted to be prepared. They wanted to know exactly what was going to happen ahead of any changes actually being made. They also recommended gradually tapering opioids and requested a trial and error period in which they were able to try out a dose reduction or a discontinuation, but still have the opportunity to provide feedback, make changes, and even the option to return to their initial opioid dose if that's what they determined worked best. Unsurprisingly, they really highlighted the need to ensure access to effective alternatives to opioids. This was particularly important because they also cited inadequate pain management as being one of the biggest risk factors for turning to other substances when opioids are not available. Along these same lines, they wanted a holistic approach to pain management that included psychosocial treatment. They also recommended providing psychoeducation about the potential consequences of using other substances in the context of opioid deprescribing. And finally, they recommended involving family members and peers for additional support. Our next step is to conduct focus groups that are comprised of older adults who have already discontinued their opioids to learn more about their experiences of what worked well or what could have been more helpful in terms of reducing risk for non-prescribed opioid and non-opioid substance use during opioid deprescribing. And ultimately, we hope to use these findings to develop an opioid deprescribing intervention that aims to maximize pain and health-related benefits while minimizing the risk for adverse substance-related outcomes. I'd like to thank my team at the Center for Aging and Serious Illness, as well as USDeN for this pilot award, and the Stakeholder Engagement Corps and my study advisors for providing lots of helpful feedback on the focus group interview guides. Thanks so much.
And we will have plenty of time, we hope, at the end for questions and discussion for each of the presenters. So next we have Dr. Malini Neelamagam. She's an assistant professor in the Department of Population and Community Health at the University of North Texas Health Sciences Center. She's a PhD trained epidemiologist, and her research focuses on enhancing successful aging in historically underserved populations with a focus on cognitive aging, and she's also one of our pilot awardees through USDeN.
Hi, thank you everyone. Thank you for the opportunity to share about the pilot project that we are currently working on, titled Understanding Barriers and Facilitators of Deprescribing to aid the development of a shared decision-making aid for deprescribing for older Latinx adults with multimorbidity. Older Hispanic adults are reported to accumulate multimorbidity at a faster rate compared to non-Hispanic white older adults. And because of this, deprescribing can be particularly beneficial for this population. Factors such as poor communication between the clinicians, the patients, and their caregivers, as well as negligence in taking the patient's values, beliefs, and preferences can be a significant barrier in successfully deprescribing for many minority populations, and this includes the older Latinx adult population. So we envision a goal where we would take a shared decision-making approach that is built on the 5 tenets of age-friendly care. And by doing this, we can uniquely address the healthcare belief, behavior, and preferences of older Latinx adults and their caregivers. And this can potentially result in concordance in deprescribing for this population. So our pilot project has 2 main aims. The first aim is to identify provider level, patient level, and caregiver level facilitators and barriers to deprescribing in older Latinx adults living with multimorbidity. And in the second aim, we will develop a shared decision-making aid which will be informed by the findings from aim 1 to support deprescribing for multimorbid older Latinx adults. This study is currently being conducted in the Dallas-Fort Worth Metroplex, which is ideal because the Latinx population makes up the largest race and ethnic demographic group in Texas. We work closely with our community partners. They include the Center for Older Adults and the North Texas Primary Care Practice-Based Research Network, which has both the organizations which have deep-rooted connections to community partners, including the Hispanic Wellness Coalition in Fort Worth. Participants of this study come from 3 main groups that we consider as stakeholders in shared decision-making for deprescribing. They include clinical providers who care for older Latinx adults with chronic conditions. They are the older Latinx adults themselves and their unpaid caregivers. Stakeholder participation is a key aspect of our study. Stakeholder participation is heavy in both of our aims. In aim 1, our stakeholders, who are the providers, the patients, and caregivers, give us feedback on the facilitators and barriers of deprescribing, and we elicit this through in-depth interviews. We'll conduct 30 interviews, 10 in each group, and the feedback from these interviews will then inform the development of a prototype of a decision-making aid. And in aim 2, this prototype will then go through revision and feedback from a stakeholder advisory committee, which will be consist of our physicians, our patients, and caregivers. And in this step, we'll go through 3 focus group meetings with our stakeholder advisory committee using a nominal group technique, and we will revise the shared decision-making aid. So where are we right now? We are almost done with aim 1. We have completed the provider and the patient interviews and have completed about 50% of the caregiver interviews. And I'd like to share some of the themes that have come up. Among providers, the theme around barriers and facilitators for deprescribing are centered around medication source, knowledge, and resources. providers have mentioned that they're unable to monitor medications, particularly those that are not prescribed by them. And they highlight that the patients themselves do not understand what is deprescribing. And not just the word deprescribing, but the concept behind stopping or changing medications. And providers don't necessarily use all the resources that are available for them. And when it comes to communicating with Spanish-speaking patients, providers who do not speak Spanish need an interpreter, and they mentioned that this cuts into their visit time. So if they had 20 minutes of a patient encounter, that is cut down significantly, and then that makes deprescribing not actually a priority in those meetings. And you'll see that the themes that emerge with the patients correlate with what the providers mentioned. Medication source comes up again. In the Latinx population in Texas, there's a lot of crossing the border to visit family, and every time they do this, they come back with medications, and this correlates with what the providers say, where they can't deprescribe something that they didn't prescribe or have no record of. Some patients also mentioned about sharing medications with a loved one, and this is not necessarily shared with the provider. They are unaware of deprescribing and the role that they can play. They are unaware that they can actually initiate a discussion about deprescribing with their provider, and they are not really aware of what medications they are on and what they actually do. And because of that, are not able to link side effects to the medications that they're currently on. And finally, with the caregivers, we find that caregivers in this population play a diverse role. So you have caregivers who are facilitating consumption of medication, so they would take the medication, give it to the patient's hand, or they create those pill box for their patients. But there are also caregivers who are actively managing the patient's care. And these caregivers receive directions about medication directly from the provider. And because of that, they are a key component in decision making for deprescribing in this population, and they influence the healthcare decision making of their patients. So our next step now is to complete these interviews, and then hoping to have a prototype of the shared decision making aid, which then can go through into for further refinement and revision. Thank you.
And lastly, we have Dr. Hoonjin No, who you heard from earlier as part of our pharmacoequity panel. She's an associate professor of social work at the University of Alabama and a scholar in the Deep South Resource Center for Minority Aging Research. Gerontological social worker, her research focuses on deprescribing and non-pharmacological pain management among chronically ill older adults, especially those living in rural communities, and racial disparities in end-of-life care, and also one of our pilot awardees.
Right, hello, it's me again. And I gave you a little spoiler earlier today about my study, but again, my pilot study is about views of deprescribing and non-pharmacological pain management among older adults with multimorbidity and chronic pain. And I want to take this opportunity to thank the USD Prescribing Research Network for its pilot funding and guidance. So we had two research questions for this study. The first one was the socio-demographic and medical factors associated with older adults' attitude toward deprescribing. Oh, okay. Is it better? Yeah, okay. I always overestimate the power of my voice. So, and the second research question was about their views on deprescribing and non-pharmacological pain management. And first research question was examined using a quantitative survey method, while the second question was examined using a qualitative research approach. Our sample was recruited in partnership with local chapters of Area Agency on Aging throughout the state of Alabama. And our sampling criteria was those 65 years or older, community dwelling, intact cognitive ability, which was assessed by telephone mini mental state exam, have a minimum of 2 illnesses lasting a year or longer, have pain lasting 3 months or longer, and finally taking medications regularly for the identified chronic illnesses, and also pain medicine for their chronic pain. And survey and interviews were all conducted by phone, and interviews were conducted with volunteers among those who already completed the survey. And our independent variables were socio-demographic variables such as age, gender, race, marital status, and income. And dependent variables used for today's presentation were derived from the revised patient attitude toward deprescribing, a validated multidimensional questionnaire that measures patients' attitude, knowledge, and experiences related to medication discontinuation. It originally has 22 patient-directed and 19 caregiver-directed questions, but our study adopted 21 of them with 5 questions in each of the 4 factors: burden, appropriateness, concerns for stopping, and involvement factor. And 1 question was about their willingness to deprescribe 1 or more of their regular medicines if their doctor said it was okay. We recruited, as of last week, we recruited 145 participants, but in this analysis, we included 139 of them. They are on average 72 years old, the majority of them female and Black. Somehow we had such difficulty recruit a male participant on this topic. So I think that says something about people's willingness to talk about their medication and deprescribing. And the majority of them were living without a spouse or a partner and had an average of 15 years of education, so more than high school. And the majority of them had a household income in the range of $10,000 to $25,000. Health-wise, they reported more than 6 pain sites measured by questions adopted from the Philadelphia Geriatric Center Pain Scale. On average, they reported more than 4 different chronic illnesses, and counting both the prescription and over-the-counter medicine, they were on close to 2 pain medications and 6 additional medications to manage their chronic health conditions. And I briefly mentioned already, but 83% of our sample was taking 5 or more regular medications. And although my sample's rate of polypharmacy is higher than the national average, but a smaller percentage of our sample shared their willingness for deprescribing. And more specifically, compared to 90% nationwide, 77% of our sample said they would stop 1 or more medication if their doctor said it was okay. So our analysis revealed factors associated with different factors in the patient attitude toward deprescribing. The number of their regular medications, excluding pain medicine, was positively associated with the burden factor, financial, logistical, and psychological burden factor. And their pain scores showed positive association with one of the items from the appropriateness factor, which was their belief that their medications were causing side effects. And the pain scores were also positively associated with their concerns for stopping. What stood out for me from these findings was that older age and Black race were negatively associated with the involvement factor, meaning older participants and Black participants were less likely to be involved in information seeking and decision making for their medications. And older participants were also less likely to be willing to deprescribe. However, participants who were married or living with a partner were more likely to be willing to deprescribe. Our study was designed again as a concurrent mixed method study. So along with the survey, we conducted individual in-depth interviews. So far, 30 participants volunteered and were interviewed about their experience with their regular medication, including pain medication, and they were asked to discuss their interest in and thoughts about deprescribing and non-pharmacological pain management. And their responses boiled down to perceived facilitators and barriers to deprescribing, as well as their needs in deprescribing. For facilitators, their interest in holistic pain management, concerns for long-term side effects for some of their medications, and desire for better quality of life help them to be interested in deprescribing and non-pharmacological pain management. However, their fear of worsening pain without their current medication and reluctance to change medicine they had been on so long, and lack of support from their healthcare providers, including not enough information on deprescribing or alternative methods, or skepticism toward non-pharmacological pain treatment from their healthcare providers, made these participants hesitant to consider deprescribing. Therefore, they expressed their need for more information from their doctors about pros and cons of deprescribing in general and available options of non-pharmacological pain treatment, particularly the ones that are available in their community and within their health insurance coverage. Also, they wanted support from their family and friends for their deprescribing efforts, since skepticism from their family, friends, were not helpful when participants wanted to try something other than medication to manage their symptoms, particularly chronic pain. And additional analysis of both survey and interview data is underway, but our preliminary findings offer some take-home messages. Those with a higher number of chronic illnesses, pain sites, and medications may benefit from targeted education interventions to reduce their concerns about deprescribing and medication-related burden. Also, older and Black individuals in this age group need to be empowered to take more initiative to engage with healthcare providers for medication decision-making. So I was so happy to hear empowerment from one of the earlier presenters today. And related to this point is the need for education and advocacy efforts for older adults to improve their knowledge about deprescribing and their self-efficacy, as well as their healthcare providers' willingness to provide reliable information and have an open conversation with older adults about deprescribing. Thank you.
Is it on? Okay. So we can open it up to the audience for questions. Of course, Amanda and I have some prepared questions, but if you have any of your own for any of the presenters, feel free to step up to a microphone.
Hi. Thank you for these really wonderful presentations. They're inspiring. So this question grows partly out of some earlier comments earlier in the day, and part of it is thinking about this rural community you're working with in Alabama. And I know at Kaiser, we just had this huge surge into telemedicine. I mean, I think we were already dipping our toes in it when the pandemic hit, and so then we just started, like, everything became video visits and phone visits, and we have these living well with chronic conditions groups that we then shifted to being able to offer either synchronously or asynchronously. Do any of you see, like, telehealth or the ability to access, say, education and support through Zoom? Like, is any of this accessible to your population, or is it that same sort of, like, computer literacy and broadband as, you know, barriers in that as well?
This is your rare opportunity to hear so much from a social worker in the room, but yeah, I will take the opportunity. So again, I want to emphasize the age group that I work with is older adults, and oftentimes, believe it or not, some of them still have these flip phones, the grandma phones that we used to call. So all this fancy web-based intervention has been very much struggling to reach that population. For example, like many of them do not have email addresses, or they may have that their grandchildren created for them, but they don't know. So whenever I ask, do you want a gift card via mail or email? Email is faster, and they're like, I don't have email, just send it to me in snail mail, and that's what I've been doing pretty much all the time. So telehealth, they're aware of it, but when it comes to pain management, they really want this interaction with the doctors. And if you really want telemedicine to be successful in terms of pain management, I think the caregivers need to be educated about effective pain assessment in the home setting, so that when the older adult patients are communicating with their healthcare providers over telemedicine, the caregivers should provide their own assessment of the pain, and also the medical regimen that they are helping the older adults to on. But still, it doesn't solve the problem of lack of broadband services and reliable smartphones. And the University of Alabama has been working closely with the community senior centers to educate them about how to use a smartphone. But when it comes to like health communications, they just stick to their older habit. So, but the work is still in the progress.
Yeah.
Thanks. I'd just like to add, I agree. I definitely don't think telehealth is the answer for everybody, as there are still obviously numerous barriers to accessing it for some people. And for some people, I do think it offers a way to access non-pharmacologic treatment that they otherwise couldn't access if they're not able to leave the house or find transportation, et cetera, to get to appointments. So I do think that it is an important part of the solution for increasing access to things like cognitive behavioral therapy, which we know is a really effective chronic pain treatment. So I don't think it should be ignored as a potential avenue for future work.
And I can add briefly also that with that Medicare medication therapy management program, most of those kind of consults are done via over the phone, and so that has historically already been in place. But again, to your points, I think I've heard, there are some cases where it is better where it's face to face, but there is that balance of being able to increase accessibility. So yeah.
Thank you.
So we briefly did another study that looked at how care was pivoted when the pandemic happened, and using telehealth. And one of the questions that we had for the providers was, how did you manage medication with telehealth? And the providers mentioned that one of the plus of having telehealth is they could now see the medications the patients were taking that they could not, because now it's not self-report. They could say, okay, go bring the bottles of all the vitamins and everything that you're taking. They also had access to seeing the environment that the patient was in, and they could see, like having eyes into their home and seeing how that looked like. And also the caregivers at home who were managing their medication, who were not making the visit. So we, in our current interviews, we explored this idea of like, could you have a deprescribing visit? Could that be a visit that you didn't need patients to come in person, and could you do it on telehealth? And that was well received.
So one of the themes that I've heard from several of your presentations is around social support. And I'm wondering if you could comment on what kinds of social support you envision would work well in the populations that you were studying around deprescribing.
In our focus groups, participants recommended having actual support groups. So a few of them were part of chronic pain management support groups already, but they were talking about using those sorts of support groups as a way to find alternative pain management strategies as opioids were being deprescribed. So I think that's something we could consider.
again, going back to the role of caregiver, I've also seen many cases that these older adults are on multiple vitamin and nutritional supplements, but not really knowing what they are for. Then I ask, whether they consulted with their doctors if all these supplements are okay to be taken with your regular medication. Then what they say is, I'm not sure, but my daughter said it's going to help me with this or that. And I ask, oh, is your doctor a nurse or MD? And no, she's a housewife. And so I think the role, I think one of the presenters talked about the medication that is not captured on the patient's record. We can only imagine what they're taking or doing out there, and not all of them may be safe currently, maybe interacting with their current medication. So I think, again, it really is important to involve the caregiver in the discussions to really on the same page in terms of who this older patient is seeing for their prescriptions and what they're taking, what prescription, over-the-counter, additional materials they are on. I think those kind of knowledge and shared communication is really important.
So, excuse me, so that brings me back to some work that I did many years ago around medication reconciliation, which is making sure patients are taking the right medications and we're aware of them. So it sounds like, knowing what they're taking is a big deal. And this is a question for Anna. I was wondering, in MTM, is there any allowance or support for pharmacy technicians being involved in that, getting the medication history? So we've done some work for pharmacy technicians to have a clinical role in the hospital setting to get that medication history. And I'm wondering if MTM has thought about utilizing pharmacy technicians at all.
Yeah, that's a great point. They have. So some of the pharmacies are always looking for ways to figure out how to involve the team there. And so you can see there's also like MTM pharmacists, there are also nurse practitioners that can play a role, and some of them are even prescribers themselves. So they have started to do that. Oftentimes it might be through like an internship, like in your 4th year, maybe a pharmacy school, or maybe during your residency where you're rotating through the pharmacy, and then you could play a role in that. So yes, they have kind of looked at that and considered that.
Hi, this is for Dr. LaRoe. Just curious, again, this isn't really much on deprescribing, medical cannabis or cannabis use in your population. I don't know if I saw it or if you identified it. If you could comment on it, please.
Yeah, so this actually came up a lot in our focus groups. Our participants shared many experiences trying medical cannabis as an alternative to opioids. I guess, so what specifically would you be interested in? They shared lots of experiences. I mean, yeah, I don't know if you want to expand on your question.
Yeah, more if you considered that a substance use disorder that they used it, or because it's hard. Is it substance use or is it medical use?
Yeah, so I mean, a few were using it medically, a few were using it more recreationally, but to cope with pain. So what we were more interested in was using cannabis for pain coping purposes, because we know that over time, use of cannabis, alcohol, nicotine, and tobacco, many non-opioid substances can actually worsen pain outcomes. So we were asking a lot of questions about potential risk factors that people would turn to things like cannabis or alcohol to cope with their pain if they no longer had prescription opioids available. And many of them did share experiences of turning to cannabis and other substances to cope with pain. I think it's an interesting topic that we still need a lot more research on. I think there was just recently some data coming out showing that there's very small effects of cannabis on chronic pain management, so I don't know if that's the answer. But yeah, it's definitely something that older adults are turning to So I think it's something that we need to make sure that we're assessing, particularly if we're considering deprescribing opioids, because there is a possibility that they're going to turn to that to cope instead.
I'll just comment from Amanda and I's experience in doing 2 randomized clinical trials where we explicitly ask patients about over-the-counter medication use and supplements. And I mean, this came up a lot. So in addition to just regular medication reconciliation for prescriptions, we found that it was incredibly important to ask explicitly about all over-the-counter medicines that were being used, nutritional supplements, and CBD products were self-reported quite frequently, and these were, studies that were all with older adults. So we were surprised by how many of those different types of medications they were using, in addition to meeting criteria for polypharmacy for their prescriptions. And we also found that they were often the ones that were most challenging to deprescribe, that people had really firm beliefs about these types of over-the-counter medicines and supplements, and it was hard to convince them otherwise.
Hello. This is a quick question for Dr. Leroux about the retrospective EHR data that you looked at. The 2 different groups, the gradually deprescribed and the abruptly deprescribed, did they differ at all in their baseline characteristics, like age, sex? Like, who's more likely to have such an abrupt discontinuation of their opioids?
Great question. So we did look at just some basic socio-demographic information that we had available, and women were more likely to have an abrupt versus gradual discontinuation than men. And then also Black African American patients were more likely to have an abrupt versus gradual than other races.
Thank you.
So one of the other themes that we heard through the presentations was patients' fear and knowing what to expect in the deprescribing process. So I'm wondering if you could comment on how can we as prescribers and people in healthcare help prepare patients, and what, not only information, but maybe, the length of time it's going to take, or what are the kinds of details that we need to be sharing about the process to allay their fears?
I think in our interviews, one of the themes that came up was, having this conversation about deprescribing earlier. It's not a conversation that you start at the point where you're going to start deprescribing. You start that conversation earlier with the patient saying, oh, hey, in a year's time, we might want to look at this medication. And that gives the patient sufficient time to go talk to their family, discuss about this. So having, sort of giving heads up to the patient so that they are prepared.
And I also want to add, always sharing specific case examples or anecdotes of other patients who are like a similar disease trajectory, but definitely had like benefit from deprescribing. It's usually easier to register and digest from lay people's perspective. And I think incorporating that kind of examples in the conversation with the patient and caregiver will be really helpful, especially to address some of the skepticism expressed by the caregivers. And many of them, they are very well intended, sometimes too overprotective. So they'd rather just to exert every possible solution out there, and some of them still think like pharmacology and medications are more scientific than non-pharmacological solutions. So if an older adult want to try acupuncture, for example, like the older adult who has mobility issues will have to depend on the caregiver, but the caregiver is not in for the idea of trying acupuncture. It'll be really hard to be actualize that plan. So I think like providers can be very cognizant of like picking up any potential signs of skepticism in caregiver, and then try to facilitate the conversation between the patient and caregivers as well.
Yeah, I think just making sure that the conversation starts early is what our focus group participants told us. They wanted to know exactly what was going to happen well in advance of those changes actually coming into play. And as I mentioned, the other thing they really wanted was a trial and error period. So knowing that these are temporary changes or not definitely permanent changes, they considered to be helpful for alleviating kind of the fear of what might happen in the context of deprescribing. And they also, in terms of the planning, wanted to know exactly how they were going to manage their pain in the absence of pain medication. So not just planning for the dose tapering and discontinuation, but also planning for the alternative pain management strategies.
And I think another part of this too, which is difficult to think about, but is not just all of the support to give to the patient and the caregivers, but also like all the different providers that the patient sees, because if one provider recommends something and the other one doesn't recognize that they're trying to deprescribe, that's a huge barrier, and then they will just lose all their trust, and all their fears are going to kind of build. So I don't know how you really kind of solve that, but thinking about, is there a way to better involve all the different providers or apply some kind of care coordination strategy, having the time to be able to do that, all of that. So, yeah.
Well, and that issue came up in our earlier panel, right, about the lack of continuity of care. You have the access issue and continuity, and you can't really do a trial and error period without continuity, without repeat visits. And so that is also, I think, contributing to the fear. I think, Dr. No, it was your talk earlier on that panel that was, commenting about they don't know when they're going to see a provider again, right? And so they might feel a lot less comfortable trying a dose reduction, not knowing that they're going to have an opportunity to increase it back up.
Hi, Caroline, from Duke. I know Anna. I just have a comment, actually, not really a question, on the discussion you were just having. I'm a primary care doctor, and I try really hard to deprescribe meds for my patients. And one other thing besides other providers on the patient's care team that I notice is when they get admitted to the hospital, like all my efforts just go down the drain. And either the medications that I started get deprescribed because of concerns during the hospitalization, or get deprescribed kind of too quickly, like opioids, for example, or medications get added on, and then you have to start all over from the beginning. And I don't really have a solution, but just that's another complication.
You can blame us, the hospitalists.
Let the hospitalists respond to that.
No, I mean, I think what we're bringing up is this idea of care coordination across settings and across providers, whether they be generalists or specialists. And there has to be transparency, right? So when patients are seeking care in different health systems, that's a problem because we're not sharing that data. So I'm sure that as we get more technologically advanced, hopefully there are some solutions around that, but it really does rely on being as descriptive as you can. Why are you stopping a medication, right? Not just it's gone from the record, one day to the next, but I think a description is helpful. And our medical record doesn't always support that type of information, right? So we don't, and I know there's been some work on timelines of medications, like I've tried this and this and this with this patient and none of them worked. And so then you're not going back and trying the same experiment again. But we don't have that way of capturing that information over time. That's really important. But you bring up a really good point about, care coordination, which I think sometimes hospitalists don't want to de-prescribe anything because they don't feel the ownership because it's not their patient in the outpatient setting. And we're trying to break through that bias.
Oh, I think it also brings us back to the theme that we keep hearing about patient empowerment, right? Because they're the one common denominator across the different settings and the different providers. So not that we shouldn't be paying attention to, better strategies for improving care coordination, but to the extent that we can empower the patient to carry that information with them and embolden them to say, every time you see someone, take your list with you, take ownership in terms of making them aware of all the different pharmacies you're using, all the different family members that are involved in helping you with medication management, all the different providers you're seeing, especially if you're seeing somebody who's outside, in a different system, or you landed in an emergency room, one stayed over, during vacation or something. So just, really educating the patient about how important it is for them to share that information with all their providers until we figure out how to fix our system.
And one more.
Amanda, I was just going to add to your comment about documenting rationales for decisions that are made. And earlier we heard some discussion of AI and other NLP type tools being used as part of deprescribing evidence generation, and a project that Cynthia and I have been working on for several years involves trying to use the text in the medical record to understand the instances of deprescribing and then the subsequent sequelae, if any, from that. And so having that documentation in the EHR, no matter whether it's ambulatory care or inpatient care, is incredibly helpful in generating the evidence about whether it really happened, and if so, how.
Yeah, we're out of time. Well, that concludes this session. And I guess Mike is going to tell us what we're doing next.